have you join us. And as we're all reflecting on the last year and looking ahead and planning for the new year, we wanted to take some time to discuss the new updates to the Medicare Physician Fee Schedule for remote patient monitoring in 2021. They were just announced by the Centers for Medicare and Medicaid Services on December 1st and will be taking effect on January 1st, 2021. Also, we want to make today as interactive as possible, and we encourage you to please submit your questions throughout the call as they come up. We're happy to pause throughout and answer them, and we'll also leave some time for Q&A at the end of the discussion. You'll see there's a Q&A button at the bottom of your screen where you can submit questions. And with that, I'm so excited to introduce you to HealthSnap's co-founder and CEO, Samson Magid.
Thank you so much, Sunny. And again, welcome all. And thank you guys all so much for taking time out of your busy days to learn a little bit about what the changes are for 2021 for remote patient monitoring. So I thought it'd be really helpful just to break it down in a really simple way, highlight some of the upcoming changes or lack thereof, and give some insight into how to pull it all together into actual practice. So we'll go ahead and get started. I'll start off today's discussion with just a basic overview of what remote patient monitoring is. It seems to have been the flavor of the month if you've ever been to Baskin-Robbins in 2020, as people are looking at new modalities of meeting patients while they're home. COVID has really shed a light on managing patient care outside of traditional care settings. I'll then break down each of the changes from the Medicare Physician Fee Schedule. And what I thought would be helpful is to actually give a color code through each descriptor. So if there's green text, it's a positive change, meaning it's going to be a little bit more feasible to incorporate that change. And if the text is red, then it might have been a limitation or a lack of change that we were hoping for in the fee schedule in 2021. And then I'll wrap up with actually putting it all together, everything from how to order RPM and who can order RPM, enrolling patients and ensuring that you have proper data transmissions for that care management. And then at the end of the day, actually furnishing the care management services throughout a calendar month and spending time with that patient throughout the month. So I'll start off with just a basic overview of what remote patient monitoring is. At HealthSnap, we always say the phrase that chronic conditions happen outside the clinic, and so should patient care. And remote patient monitoring is just that. It involves the collection and analysis of patient physiological data that could be blood pressure, weight, resting heart rate, glucose readings outside of a traditional healthcare environment, i.e. the patient's home. This data is then used to develop a treatment plan in relation to a chronic and now acute health illness or a condition. Medicare released these 4 codes that you're seeing here actually in January of 2019. They expanded in 2020. And now with the new regulations in 2021, have added some additional clarifications. Just to give an overview of each of the 4 codes, the first one is 99453. That's patient setup and education. So actually facilitating the care plan, setting them up on a connected device, and educating them on the benefits of a home monitoring program. The next one, 99454. Is 16 days of remote data transmission every 30 days, meaning that the patient has to transmit a physiological data point at least 16 times within a 30-day period. The next is the care management codes, 99457 and 99458. 99457 is the first 20 minutes of furnishing care management services and interactive patient communication. And then 99458 is each additional 20 minutes of data review or communication with that patient. And those are billed in additional 20 minutes, units of additional 20 minutes for the 58 code. So let's jump right into it and actually break down the changes for these 4 codes and the actual facilitation of a remote patient monitoring program. So what are the top changes to the fee schedule in 2021? First off, it's for 99453, which is the patient setup and education code. During COVID-19, there was a waiver that allowed all auxiliary staff, not only clinical, to set up and educate patients on RPM services, and that could be contracted or employed by that physician group. Happy to share that CMS has finalized that waiver. So starting in 2021, any auxiliary staff is able to set up and educate a patient with a remote patient monitoring program. Next is the 99454 code. As you can see, we had our first red lack of change. CMS, despite stakeholder commentary, did not change the days of data requirements. So to successfully bill for 99454, the patient is still required to transmit at least 16 days of remote physiological data in a 30-day period.
Samson, we actually had a question come in on this exact topic.
Yep.
Can a provider bill for CPT code 99454 multiple times in 1 month if the patient has multiple devices?
Got it. Yeah, that's a really great question, and it's a really frequent one as well. So right now today, if a patient is ordered for multiple devices, let's say for heart failure, and they're monitoring their weight, blood pressure, and pulse ox, O2 sat at home, that patient would only be able to be ordered and billed for 99454 one time. So even if there's multiple peripherals being transmitted, you can only bill for the 54 code one time per patient. Now, there is some ambiguity around if a patient has multiple comorbidities. So let's say a patient was ordered for uncontrolled hypertension and they're obese and you want to monitor their weight separately. There is still some ambiguity about whether or not you could bill for each beneficiary one time in a month or for multiple programs in a calendar month. So that is still up in the air today. But if it's for one order and one condition, you can only bill for the 54 code for one data point per month. And thank you for the question. That's a great one. Moving forward. So this one was the hot topic. When the initial fee schedule was released on December 1st, it was originally written for 99457 and 99458 that it was 20 minutes or more of clinical staff, physician, or other qualified healthcare professional time in a calendar month requiring interactive communication with the patient during the month. And what they said specifically was, at a minimum, a real-time synchronous two-way audio interaction that can be enhanced with video or other kinds of data transmission. Boiled down, this initial ruling made the business model not feasible to actually bill for 457 and 458. This was requiring a qualified healthcare professional to actually spend 20 minutes of real-time communication via phone call or video conference with the patient every calendar month, which made it very difficult to incorporate this program at scale. Fortunately, based on commentary to CMS throughout the time period, they actually changed this. And in the final proposal, they responded to comments and clarified that the 20 minutes of time required to bill now can include time furnishing care management services in addition to interactive communication, meaning that if I'm spending time setting up the patient on the program, as the data comes through in the month and I'm reviewing that data and determining how to change the care plan accordingly, that time spent reviewing the data also includes the time that you can use for 457 and 458. So that was a major change to the final ruling. Just so everyone knows that the advanced copy of the 2021 final rule has not been published yet, so you won't see that change in the proposal there. That is anticipated to be published on December 28th. So this was the most contradicted change in the ruling, and very fortunate to see that they did go back and provide some clarification on what is billable time for 57 and 58. The next is patient consent for remote monitoring. So there was a waiver during COVID that patient consent could be obtained at the time of service. As you can see in green, that they did finalize this. So that's great to see that the waiver was finalized in 2021, meaning that you can get a patient consent right when you furnish an order RPM, as opposed to prior to the commencement of the service with the patient. Next is RPM for established patients. During COVID-19, they did not require the patient to be an established patient. And what they've done now, again, as you can see is green, did require that it needs to be an established patient after the PHE, but that it can be established via prior E&M service. What's nice about this, and as we're starting to see the light and the increase in patient reach with virtual care, is that CMS did not specify whether the E&M service must occur via an in-person visit rather than by telehealth. So the interpretation here is that you could establish a patient via a telehealth visit, i.e. it is an E&M code, and then be able to then order RPM for that established patient without them actually having to physically come into the office. The next one is another major change to remote patient monitoring in 2021. Prior to 2021, so in 2020 and before, a patient was able to manually submit data in an application to send it to the care provider that was monitoring them. CMS has now changed that ruling to requiring the use of connected devices, meaning it has to be a Bluetooth, Wi-Fi, or cellular-enabled peripheral device that transmits that data passively from the patient's home to the care provider without the patient manually entering data. This ruling was changed because of concerns about data integrity and validity, but there is commentary now and concern about patients that either don't have access to medical devices. During COVID-19, there was shortages of medical devices and access to those as well. But this was the final ruling that requires the patient to now use a connected device and can no longer, as of January 1st, manually submit data for 99454 requirements.
Samson, we did have a question come in on the 20 minutes. Does the entire 20 minutes need to be by a healthcare provider, not staff?
Yeah, it's a great question. And I am going to pull that together on the next slide. But to answer that right now, remote patient monitoring is actually billed under general supervision of the ordering provider, meaning that any qualified healthcare professional can spend that 20 minutes a calendar month with the patient. So typically it's a medical assistant, an LPN, an ARNP, they can be a nurse practitioner, they can be the ones, an LPN that is reviewing the data with the patient. And if anything escalates, you can go to the provider, but the 20 minutes of time for the 5.7 and 5.8 codes can all be spent by any qualified healthcare professional under the general supervision of the ordering provider. And the last two changes that came through in the fee schedule, there was a lot of commentary about RPM by therapists, which includes physical, occupational, behavioral health therapy. Unfortunately, CMS declined to enable RPM services for these types of therapists and very clearly stated that RPM can only be ordered and billed by physicians, nurse practitioners, or physician assistants. And last but not least, this is a contradiction to CCM programs, the chronic care management programs, and is consistent with 2020. Unfortunately, we were hoping that there might be some changes for rural health centers and federally qualified health centers in 2021. But again, CMS unfortunately declined to extend RPM reimbursement as a standalone service, basically stating that the care management services are included in the all-inclusive rate for RHCs and the PPS for FQHCs. This is in direct, as I said, contradiction to CCM, which is an eligible service for these groups. And unfortunately, RPM in 2021 is not a separate and distinct billable service for RHCs and FQHCs next year. So putting it all together, again, remote patient monitoring involves, number one, developing a treatment plan informed by the analysis and interpretation of the patient's data from home. The ordering provider, the goal is to manage that treatment plan with the patient until the targeted goals of the treatment plan are achieved. That denotes the end of an episode of care. So if I'm saying, hey, I'm ordering for a patient with uncontrolled hypertension, and my treatment plan is to get them to blood pressure readings in control below 130/80 consistently for a 2-month period, they would stay on that monitoring program until they achieve that targeted goal of the treatment plan. This is all new language that CMS has put out for remote patient monitoring, which gives more insight into the order of operations and ultimately the goal here, which is improving patient outcomes for a program like this, which is great to see. So if we put it into practice and we take all the changes that I just reviewed there together, we'll go through step by step. Number one is ordering RPM. So again, anybody that's able to order and bill for E&M services, MD, DO, ARMP, PA would order remote patient monitoring to an established patient based on medical necessity for an acute or chronic condition. Again, that E&M, that established patient just needs to be denoted by a prior E&M service that can be done either in person or via a telehealth encounter. From there, any auxiliary personnel, clinical or non-clinical staff would obtain patient consent that the patient is agreeing to the treatment plan, the clinical goals, and that they understand that this is not 24/7 monitoring and the requirements and benefits of the program. So they would receive that patient consent. That can be all done verbally at the time of furnishing the service, right, either in the practice or through a telehealth encounter. Step two then would be device setup and monitoring. This is the first CPT code, which is 99453. The auxiliary staff would set up and educate the patient on the connected health device that collects physiological data. And to clarify here, I put a little bit more that the data has to be reasonable and necessary based on that diagnosis. So you wouldn't monitor glucose for a patient with uncontrolled hypertension. It has to obviously be medically necessary for that condition that you're monitoring. So simple example, you're providing a blood pressure cuff and setting up the patient with that cuff at home for a diagnosis of uncontrolled hypertension. When the patient is set up and educated on the program, you're able to bill for CPT code 99453, which is that setup and education code. And then the step two is the ongoing monitoring. So as that patient takes their blood pressure at home, they must passively, again, they can't take their blood pressure and submit it into an application or a web application. They have to take the reading and it has to passively transmit via Bluetooth, Wi-Fi, or cellular data to the ordering provider's care team at least 16 times within a 30-day period. Once that patient transmits at least 16 days of data, you can now bill for 99454. And then the third is ongoing care management. So throughout that calendar month, as the data is being transmitted from the patient's home to the care providers, the care team can now proactively manage that patient's care plan and treatment plan and adjust things in real time. So again, this can be a medical assistant, a nurse, anyone that the ordering provider deems as a qualified healthcare professional. That time element, the 20 minutes of time, can now include reviewing or analyzing the patient's data as it comes through to adjust the care plan, and or communicating with the patient via a real-time interaction. So if I'm on the phone with the patient, if we're messaging back and forth in real time, or I'm reviewing the data and adjusting maybe a medication dosage or a medication type, that all goes into time spent for 99457. So for the first 20 minutes that you spend in that calendar month, you can bill 99457, and each additional 20 minutes, meaning that if you spent 60 minutes with the patient, you could bill 99458 for 2 units of time, which makes it really nice as you spend additional time with higher risk patients that do require that time. You're able to now bill in units for each additional 20 minutes of time you spend.
Samson, we did have a couple of questions and clarifications come in. If
Sure.
we can take a moment to stop here. So one is, does the medical device need to be FDA approved?
Yeah, great question. And again, really common. It does not need to be an FDA approved medical device, but it just needs to be recognized as a medical device by the FDA. So there is a distinction between those two. They don't need to go through FDA approval to actually incorporate it. So for example, a connected consumer health device that is recognized as a medical device could be used for our remote patient monitoring program, but it does not need formal FDA approval.
Thanks, Samson. And then we had a couple of clarifications come in regarding the 16 days of transmission. So one was, were these 16 consecutive days or just 16 days out of the 30 days of the month?
Yeah, so it's 16 days out of the 30 days. So if you had data, no data, that would work. It does not need to be 16 consecutive days.
Perfect. And then another one was, can the 99457 and 99458 be billed regardless of 16 days of transmission, as long as the 20 minutes has been covered?
Yeah, that's a really, really great question. So CMS does not anywhere disclose that you need to have 16 days of data to bill for the 99457 or 58 code. The codes are not, meaning that they're not codependent. You don't need one for the other, but they are interdependent, meaning that if you don't have data being transmitted, then what are you spending time reviewing in the calendar month with the patient? So the short answer is that technically, yes, you are able to bill for that. Is that best practices? No. Should it be a habit? Absolutely not. But there are cases where, let's say, a patient does have a critical health event and they didn't get the 16 days of data, and you are spending 60 minutes, 80 minutes with that patient in the month, communicating with them, that would allow you to bill for 5.7 and 5.8. So it shouldn't be a practice. It should definitely be the exception, but it is not a requirement to have 5.4 eligible in order to bill for 5.7 and 5.8.
Great, thanks, Samson.
Mm-hmm. Any other questions on the 3 steps here, from ordering to getting a patient set up and monitored to ongoing care management? I think I see one for CCM and RPM while we're on the topic here. So you can bill for CCM and RPM in the same calendar month. They call that stacking the codes, and that's absolutely acceptable. And most CCM patients are great candidates for a remote patient monitoring program. The caveat to that, though, is that you cannot spend the same time for both programs, meaning that to bill for 5.7 and the CCM codes, you need to separate the time elements. So you can't use the same 20 minutes for CCM and the same 20 minutes for 5.7. They would have to be 40 minutes of time in that month to bill for the 5.7 and the CCM code. But you can absolutely bill for RPM and CCM together, and it creates that data-driven approach to patient care and communication that we, in order to help facilitate that proactive management of a care plan.
Great, Samson. We had one other question come in on this specific slide for the ongoing care management column. Is there a list of categories for healthcare professionals that are covered versus not covered?
So there is no formal list. CMS doesn't denote who a qualified healthcare professional is. The default answer that I always give is that that's based on the ordering provider, who they deem as a qualified healthcare professional for their practice and patient care. So we have seen cases where it's a medical system. We have some cases where it's an LPN, and we've seen cases where the actual ordering provider is doing the time itself, which is not recommended. So that really is up to the ordering provider to denote that.
Great. I think, and we had another one that I think a lot of people have a question regarding the cost of the device. Who typically covers the medical device itself? Is it provided to the patient for RPM?
Yeah, so that's a distinction in 2021. And even going back to the 5.3 and the 5.4 code, those are both practice expense codes, which are designed to cover the cost of the connected device. I will say that there are some vendors that will cover that device on behalf of the practice and the patient. There are some vendors in remote patient monitoring that require the practice to pay for the devices. And again, the purpose of those codes is to cover that as a practice expense. So from HealthSnap's perspective, I can just say that we cover the cost of the device on behalf of the ordering provider and our partners. But there are some cases where that does fall back on the practice as an expense. And again, CMS has made it clear that the 5.3 and 5.4 code is designed specifically to cover the cost of that device during that patient's setup and education.
Great, thanks, Samson. Let's see if we had a few other come in. Could we kind of go through if FQHC qualifies for RPM reimbursement?
Yeah, so unfortunately, CMS made it very clear that RHCs, rural health centers, and FQHCs cannot bill for remote patient monitoring as a separate care management service. Again, unfortunately, it's in direct contradiction with CCM, which they can bill for, but remote patient monitoring, these 4 codes here, they are unable to bill for, unfortunately.
Thank you for clarifying that. A couple more came in, if you don't mind. One is an interesting question. Do we have guidance on how long the patient data for RPM should be stored for? Is it a certain amount of years, and who owns this data?
That's a really interesting question. And there's definitely different perspectives on that. From our perspective, the patient owns their data. They control who has access to it and who doesn't. And if there is a care team that's managing that patient, they're able to access it. From our workflows and the way that we partner with our physician groups, when a patient is now unenrolled from a remote monitoring program, any of the data that they continue to transmit does not go to that care provider. It's all patient driven, and they can unenroll themselves if they wanted to. And then if they get re-enrolled, then they're able to see that data again. So we do make it patient-centric in that regard. As far as storing the data, that again is up to the ordering providers and the physician groups that are on the program. On HealthSnap's end, we don't terminate data. It's all stored on our end.
Great, thanks, Samson.
Mm-hmm.
See if we had a couple more come in. Samson, are there any other questions on that you wanted to go through here?
Let me see. And you guys, thank you for asking all the questions. These are great questions and really relevant. So I can go through these. I think we have one about time. We see if a patient time spent is 15 minutes for one session, 10 minutes for another, 18 minutes in 3 sessions, how is it billed? So you would sum up the total time spent. So let's say you spent 15 minutes for that first phone call, 10 for the second phone call, that's 25 minutes, and then 18 minutes in the third phone call. Let me do my quick math here, 25, 35, that's 43 minutes there. Then you'd be able to, because you got an additional 20 minutes, you'd be able to bill for 99457 and 99458. So if it's between 40 and 60 minutes, you can bill for the 5/8 once. If it's between 60 and 80 minutes, you would bill for the 5/7 and the 5/8 2 times, and so on and so forth for each additional 20 minutes. And I'll just go through the questions here. These are all really great questions. Somebody had asked about the devices. If they're not Bluetooth, how does a provider account for this, and how do they train the patient and urge them to get a Bluetooth one as a part of the device, the treatment plan? So that's a really great. It's a challenge for any physician group that's looking to incorporate remote monitoring, and it goes into when you evaluate a partner for a remote patient monitoring program that can actually help facilitate the device logistics. Again, talking to HealthSnap's perspective, we manage all the devices and they're all cellular enabled. So whether you're ordering for remote blood pressure, glucose, or weight readings, we facilitate and furnish all pre-configured cellular devices as a part of being a partner in the program, so that the practice and the patient do not need to worry about the actual device facilitation. They just worry about the actual care management and improving patient outcomes over time. Somebody had asked about if a patient is done with the RPM program, can they return the device and then it can be redeployed? That's really up to the practice. We say it's up to your organization. If you say, hey, a patient will come back into the practice when they're done, you can sanitize it based on COVID protocol, and then you can repurpose it by working with our physician groups. The practices do own the devices, and they can do that on their own if they deem that that's appropriate. During COVID, we definitely did not mention that as best practices, but it can be done, and we've seen that done before. Great. Well, I think we got through most of the questions there. I'll wrap up with just some key takeaways, and then we'll end up with any additional questions that might drop through. Main takeaways again, guys, from the 2021 regulations: RPM can only be ordered and billed by physician or non-physician practitioners who are eligible to bill Medicare for E&M services. So again, MD, DO, ARMP, PA. RPM can only be ordered for an established patient, which is denoted by a previous E&M service. Data transmission throughout the calendar month must be done via a connected device now, not via a patient manually entering physiological data. CMS is still requiring 16 days of data transmission in a 30-day period to bill for CPT code 99454. And last but not least, which was the most discussed, they have clarified that the time spent for 99457 and 99458 now includes furnishing care management and real-time communication with the patient. So actually reviewing the data as it comes through and adjusting care plans in addition to that real-time synchronous patient communication all goes towards that 20 minutes of time throughout the calendar month. So I'll wrap up. We have a couple more minutes here. I know we're a little over, but if anyone has any additional questions, happy to answer them and go through here based on today's discussion. And again, a reminder, if you want to ask a question, feel free just to drop it into the Q&A box on the Zoom bar. You'll see a little Q&A there as well. If you did ask a question and I didn't get to it, feel free to resubmit it and I will make sure to get to it as well.
Samson, is it typical for a patient who has finished an RPM program to, not to return their device, but if they've reached the treatment plan goal for RPM, can another goal be established and start a new cycle of RPM?
Yeah, absolutely. I mean, that's the whole purpose of this, is to based on a diagnosis, and a lot of the chronic conditions are comorbid. So you could have an obese hypertensive and you could start off with ordering for uncontrolled hypertension, and then going into weight management and reordering RPM. So what we do is actually show each RPM program that patient was previously enrolled for. And again, you would bill for each diagnosis and care treatment plan and target outcome. So yes, absolutely, you can re-enroll a patient for another program.
Great, thank you. And then we also had a question that came in regarding the 16 days. If patients, what percentage of patients reach the 16 days, and is there anything we can do to nudge them to hit the 16 days every month and support them as they're working to improve their health and also transmit the data?
Yeah, I will say that the percentage of patients that hit the 16-day requirement, I unfortunately can't give a generic answer because it does vary from group to group and how engaged those patients are within each organization, and that practice communication throughout the calendar month. That's such an imperative part of the success of a remote monitoring program, is that you don't just order it and let it do its thing. You really have to manage the patient's care as data comes through, and that patient needs to feel that they're being monitored by a clinical staff member while they're home. Otherwise, they won't feel like there's any value to the program. On our end, we do have services that ensure patients stay compliant. So if a patient doesn't take a blood pressure reading for 2 consecutive days, we outreach to that patient through automation and actual humans calling and texting them as well. And so our job is to make sure patients hit that 16-day requirement on the behalf of our partners. But it really does need to also come from the clinical side of making sure, like, hey, we saw your blood pressure readings. Maybe we need to adjust your medication, or great job, you're taking your readings. It looks like everything's starting to move down or trend in the right direction. That interactive patient communication is so crucial to the patient staying engaged, not for the first month, but for the 3, 6, 9 months that they're monitored and on the program.
Thanks, Samson. And thank you everyone so much for submitting your questions. It was great. We wanted to have an interactive discussion, so we definitely appreciate hearing your questions. Samson, unless you have anything else to add on our discussion, we're just over, we promised 30 minutes, so we're just a little bit over, but if you have anything else to add before we wrap up.
I think we went through a lot of the questions, and thank you everyone again. Just reiterating, those are great questions and really relevant and ones that are very frequent. Remote patient monitoring is a new way of managing chronic conditions remotely, and we're starting to see, especially with COVID, that not only are the regulations in place that make it a feasible business model, but what we're seeing too is that patients are expecting it. So we're here to help make it as easy and simple as possible, not only to get started, but to scale this to your most vulnerable patients that do need to be managed and treat while they're home proactively. And we're here again to support any ongoing questions, even after the webinar. So if you do have questions, you can go to our website directly, or you can email me directly, and I'm happy to personally answer them as well. My email address is right here, and this will be shared to anyone attending as well. So feel free to shoot me a note. I'm happy to answer the questions directly as well.
And with that, we thank everyone for joining us today. We've dropped our website link in the chat. If you'd like to visit our website or request a platform demo with one of our specialists, they're excited to chat with you. We hope after today's conversation, you're able to walk away with the sound understanding of the new updates and how to easily implement them into your current or new RPM program. We will be sending out a recording to this webinar to you shortly. And in the meantime, we'd love for you to connect with our team on LinkedIn, and stay tuned. We'll be announcing a new on-demand series with Samson in January. Again, with that, we'll be following up with the recording, and please feel free, as Samson mentioned, to submit any additional questions in the meantime. We thank you again for joining us, and we look forward to talking more soon, and we wish you a very safe and healthy holiday season.